so now let's go on to the second part, which now we will talk about the colors and structures seen in melanocytic lesions. And so here are the colors that you kind of have to know what they are associated with. So we have yellow, white, blue, red, brown, light brown, and black. What is black? So black represents melanin in the upper epidermal layers or melanin throughout all layers of the skin. Brown represents melanin at or around the DE junction, right? And the higher your concentration of brown, the more melanin, the higher the concentration of melanin at that area. So browns are around the level of the DE junction, a little bit above, a little bit below. Blue-gray represents either free melanin or melanin in melanophages. So it's either melanophages or free melanin in the dermis, gives you a blue-gray color. And where in the dermis? It's usually papillary dermis and just below. Blue represents melanin in the deep dermis. And again, why do you see it as blue? It has to do with the Tyndall effect, which I'm sure all of you are aware of. So melanin, the same melanin sitting down here will appear blue, sitting up here will appear more brown and black in color. Yellow is stratum corneum devoid of blood and melanin. That's yellow. And yellow becomes an important color also when you're trying to diagnose a squamous cell carcinoma, because it's a keratinizing tumor, so the yellows become important in there. Then you have your blue-white veil overlying a palpable portion of the lesion. So you can actually run your hand across this and you can feel that it's slightly raised. And if you see this blue-white veil overlying that, it represents deep melanin and compact orthokeratosis. So those are the two things that contribute to that veil. And then you have a blue-white veil, which we are now changing the term to regression structures, but again, old terminology, hard to kill. So this is the same term, blue-white veil, but not over a palpable area, but flat. So you run your finger across it and there's no palpable component. And that represents regression. And the reason that you get a blue-white color is you have white from the scarring, and you have the melanophages sitting, giving you the blue-gray color, and this combination of blue and white gives you the blue-white veil, but because it's undergoing regression, it's not palpable. Red and orange represents increased vascularity, bleeding, and serous crust. So shallow ulcerations will give you a sort of an orange color. So here in summary, black, melanin up high or throughout all layers. Brown, pretty much in this area. Gray is melanin, free melanin and melanophages here. Blue, deep down melanin. Red, orange is your stratum corneum area. Sorry, orange, yellow is your stratum corneum. White is your collagen. And red is your vascular structures. All right, now we're going to switch and talk about the structures that define a lesion as a melanocytic lesion, okay? And we will continuously come back to this one algorithm. Bottom line is your first tier is the lesion a melanocytic neoplasm, yes or no? And towards that end, what are the structures that define the lesion as melanocytic? So the first one is having a network. And so the definition of network is either a pigment network or a negative network. Either one constitutes network, and that lesion is considered melanocytic. Now, a pigment network basically is a grid-like pattern, and it's easier to show it schematically as follows. So you have your reedy ridges, you have your suprapapillary plate. There's more melanin per unit area in your reedy ridge than over the suprapapillary plate. And hence, your reedy ridge appears as a dark line, your suprapapillary plate will appear as a hole, all right? And that's really the network. So here's your classic network of a nevus, and if we look at it histologically, you're going to see the nice DE junction, reedy ridges with the pigmentation, and that's really responsible for the network. Now, a negative network, by definition, is as follows. It consists of serpiginous, interconnecting, hypopigmented lines that surround irregularly shaped pigmented structures that resemble elongated and curvilinear globules. Now, with that said, here's is the image. So notice the hypopigmented lines serpiginously around these elongated, curvilinear, globular structures. So globules we usually think of are round to oval, right? Here the shapes are not round to oval. And that's your most blatant negative network. In reality, most of the time when you see a negative network, you'll see it like this. But if you remember the definition, you'll still see the same thing. So relative hypopigmentation adjacent to these curvilinear, elongated brown structures. Yeah, does everybody see that? Yes. And then here, notice again, the same process. So right up here, same thing, relative hypopigmentation around these elongated brownish structures. So that's the definition of a negative network, and if you have that, it defines the lesion as melanocytic. Now, what does a negative network consist of histologically? It's one of two things. It's either due to bridging of reedy ridges, or it's due to a melanocytic tumor that's sitting where the nest, instead of being a sphere, is actually more tubular in shape, right? And normal nevi, or a nevus, tends to create clusters and spheres, whereas in melanoma and in Spitz nevi, these clusters tend to be elongated and irregular, not as a sphere. And so you can already predict you're going to see it more in Spitz nevi and melanoma, the negative network. Now, the next one that defines a lesion as melanocytic are globules, and that is defined as three or more aggregated globules, and usually with a brown color. They can sometimes be blue, but usually brown in color. So globules, symmetric round to oval structures, they're well demarcated, most of the time brown, sometimes black, but rare, sometimes blue, but rare. White is a very interesting type of globule, which I'll talk about in a moment. And red is, you can see red globules, but these are not really nests. This has to do with a vascular process. So yes, there's a red globule, but when you see red globules, it really represents a neovascular process. And here's classic globules, different sizes, shapes, highlighted here. And histologically, what we see are basically nests of melanocytes. Here are globules as well, the brown. So here are your globules. And in between are sort of yellowish structures, right? So yellow, you can already predict what that's going to be. And when we look at it, you'll see that the brown structures are your nests of melanocytes, and then your yellowish structures are your keratin within this congenital type nevus that has also some milia cyst. Now, the color of globules, as mentioned, most commonly brown, sometimes blue, and if you see blue globules, it usually means it's a congenital nevus. Black, if you see black globules, usually goes more along with Spitz and melanoma. And the reason that you see the different colors in the globules, again, has to do with the Tyndall effect. And then there is this entity known as white globules. And so here's a nevus with all these white structures. If these were brown, you would actually say, oh, that's easy. That's just a congenital nevus with brown globules throughout. But now you have all white. So you think, well, what are these white structures? So initially we were thinking, are these sebaceous glands? Are these milia cyst? But none of that really fit. So it turns out if you see white globules, it actually represents a balloon cell. It represents a balloon cell nevus. So it's like kind of a cool thing to know. So if you see a nevus full of white globules, you can already predict that your pathologist is going to tell you that's a balloon cell nevus. And as I mentioned, red globules is really a neovascular process. So you have a tumor and there's neoangiogenic vessels around it, and that creates the impression of a red globule. And if you see red globules, that's a bad sign. Okay, so that means a malignancy with a deep nest that has neovascular process, and usually not a good prognostic feature. So here are your colors again. Globules in a melanocytic lesion can be white, brown, blue, and black, and red as the caveat that it's not really necessarily melanocytic. It's some neovascular process. Okay, so then the next structure that defines a lesion as melanocytic are streaks. And streaks are here. They're these linear extensions coming off the tumor, going off into normal skin. Now, in the old literature, there was a term called radial streaming, another called pseudopods. Radial streaming was a sort of a straight line going out into normal skin without a bulbous ending, and if it had a bulbous ending, then it was called a pseudopod. Okay? Basically, on a histology level, they represent the same structure, and therefore these two terms have been abandoned for one term that we now call streaks. So, with that said, what was radial streaming defined as? Again, linear extensions without that bulbous ending. It represented histologically as confluent junctional nests of melanocytes. And so here you have these little linear extensions here, 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 up here, without a bulbous ending, and that was your radial stream. And here's a starburst pattern of a Spitz nevus with radial streaming. Notice there's no bulbous ending. And now, pseudopod, on the other hand, is the same structure with the bulbous ending. Histologically, same thing. So confluent junctional nests of melanocytes. And so here's a starburst pattern with pseudopod in a Spitz nevus. And here's a melanoma with pseudopods, a linear extension with the bulbous end. And histologically, again, confluent junctional nests of melanocytes. And so here's another melanoma with the pseudopods or streaks at the end. And histologically, here it is. That's your pseudopod. Now, it turns out that for us as clinicians, dermoscopists, the finding of a pseudopod or a streak is very important because it tells us sort of the diagnosis leaning towards Spitz versus melanoma. But pathologists don't pay a lot of attention to this. And the question that arose is why? And what we now have determined is that it has to do with that what we are looking at is a horizontal section, what the pathologist is looking at is a vertical section. Now, here's your pseudopod, okay? When you see it on the horizontal plane, easy to identify. For a pathologist to get this image, right, means that all the stars have to be aligned in the universe. So, normally you do a section, vertical section, you cut it through there, you get a round globular structure, or a smaller globular structure, or a little bit of an oval structure. And again, only if the section occurred smack through a pseudopod, right, would you actually be able to see it histologically. And so that's why on the histology end, it's not as important as it is on the clinical end. So here are streaks coming off the main tumor body, right? They're connected to the main tumor body. And that differs from when you have a globule with a space in between. Okay, so this is not considered a peripheral streak. These are peripheral globules without that direct connection to the tumor. If you have a stalk that's connecting it, that's when it becomes a streak. And it's important to be able to differentiate between these two, and you'll see why that is in a moment. On a biologic level, both the peripheral globules and the streaks represent the same process, which is radial growth of a tumor. In a nevus, in a benign lesion, these peripheral globules, if you actually follow this lesion, this is what's going to happen over the course of time. This lesion will slowly become symmetrically larger. the globules will become smaller and smaller, lighter in color, till the nevus enters senescence, at which point the peripheral globules will no longer be visible, and the lesion will either manifest a homogeneous brown color or will manifest a network. Okay, so that's the normal growth process of a nevus. So horizontal growth, these peripheral globules represent that. And what is actually happening is that these globules, these peripheral globules, represent these junctional nests of cells at the tips of the reedy ridges. And when we follow these over time, and we actually did that with a study with confocal microscopy, what we found was that basically the globule migrates across the reedy ridge. So schematically what's happening is that this is the peripheral globule, and as the lesion is getting bigger, this is now moving here as depicted as follows. So it's kind of just moving out horizontally across, and once it's under senescence, these nests actually kind of involute or become non-visible. Now, the streak, on the other hand, on the same hand, is that it's again horizontal radial growth, and so obviously in a melanoma we're not going to follow. But if you had clear-cut, no question about it, pigmented Spitz or Reed's nevus with a perfect starburst pattern, okay, you can already predict its growth. It's going to do this. It's going to grow in a symmetric fashion, and the pseudopods will become smaller, or the streaks will become smaller, and eventually when this Spitz or Reed's nevus enters senescence, those structures will disappear, and you'll end up with a homogeneous nevus with a central blue-white veil, okay? Because the Spitz nevi have a lot of depth to them, so you're going to see the bluish color there, as opposed to, say, the benign, the run-of-the-mill type of nevus, which is growing is more superficial, so it ends up being as a network. So you're going to see a central blue-white veil. And then the final, or one of the final features of a melanocytic lesion on your skin, excluding face and palms and soles, is a homogeneous blue color. And that really defines a blue nevus. Now, there are two areas of the anatomy that require special attention that, again, with the 2 hours or 2.5 hours allotted, going to be difficult to cover everything, but suffice to say that for the face, we have a pseudo-network pattern, and for the palms and soles, we have a parallel pattern, which are added features that help you in the diagnosis of a lesion as melanocytic in these areas. So parallel pattern on the palms and soles, we'll talk about that when we talk about melanoma, and a pseudo-network pattern on the face. Parallel pattern basically is due to pigmentation that sits in either the ridge or the furrow of the skin. So you have your ridge, this is the furrow. The ridge is really the dermatoglyphic, right? When you put your fingerprint, you're getting the dark ridge as your fingerprint, that's your ridge, and then here's your furrow. Now, nevi like to grow on the reedy ridge, that is associated with the furrow, and therefore the pigmentation will be in the furrows. Melanoma likes to grow around the acrosyringium, okay, and I'll show you that in a moment. So here, so melanoma likes to grow around the acrosyringium, and therefore the pigment in melanoma tends to be on the ridge because the sweat glands open up on top of the ridge of your fingerprint, right? So you get a parallel pattern again, but on the ridge. And then on the face, you have a very blunted DE junction. And so what you are really looking at is the osteal openings with pigmentation around them, okay? So it's called a pseudo-network pattern because it's not truly due to the reedy ridge pattern. And there's a host of structures that you have to know, which is a course in itself. And it has to do with granularity around the osteal openings and pigmentation and the way the pigment around the osteal openings is distributed. We'll talk about it briefly when we talk about melanoma. Okay, so those are your melanocytic structures right off the bat. We will talk about the non-melanocytic lesions in a moment, and if it's not a basal cell and a seborrheic keratosis and a hemangioma, and you have now no features of this lesion, you now need to look at the vascular structures, and depending upon the morphology of the vessels and their distribution, you can still classify a lesion as melanocytic or non. And for that, if you want to see an in-depth article about the vascular structures seen in melanocytic lesions, this is the article in the Archives of Dermatology, published in 2008. And so a whole slew of vascular structures that we encounter, but the most important ones are as follows. Dotted vessels, if you see that, its positive predictive value that you're dealing with a melanocytic lesion is 90%. Okay? You can see it in a host of other lesions, including psoriasis and clear cell acanthaoma and porokeratosis. But again, positive predictive value for melanocytic, 90%. And what melanocytic tumors will manifest dotted vessels? Most commonly melanoma, but then you can also have your dysplastic nevi and some congenital nevi and Spitz nevi as well. So here is a lesion. Notice the dotted vessels throughout. It also has the crystalline structures. This is a lesion that actually the pathologist, a group of pathologists, could not tell us exactly what it is. Spitz versus melanoma, yeah? There was no way to know exactly what this was on the histology level. Another melanoma, dotted vessels. And then the comma vessel is a sort of a curved vessel. Positive predictive value that is an intradermal nevus is 94%. So it is a negative predictor of melanoma. And that's also what bore out in this study, is that the comma vessel is a negative predictor. So if you have comma vessels as your predominant vascular pattern, you're dealing with an intradermal nevus, not a melanoma. And so here are your comma vessels, and another example of comma vessels. Okay, so now we move forward. If you don't have any vascular structures that define the lesion as melanocytic, now all other lesions by default are melanocytic. And the reason for that is that you don't want to miss a melanoma. So if you can't diagnose anything up here, right, you're left with a lesion without any features to help you make a diagnosis, then you have to always keep melanoma in your mind. And so these so-called featureless or structureless lesions are often not completely featureless or structureless. They can be tan like this, but they can be very darkly pigmented. They can have these regression structures. But again, they're not, you can't define the lesion as melanocytic or non based on this algorithm. Okay, now, there are structures that we see in melanocytic lesions that can help you decide whether the lesion is benign or malignant, but these structures don't define the lesion as melanocytic. Okay? So, dots. Dots, basically you can think of very small globules, end up being dots. They can be black, brown, blue-gray, or red. But again, red really represents blood vessels. Blue-gray, you now know, is your melanin, free melanin melanophages. Brown would be small nests at the D junction or slightly above. And black dots represents melanin in the stratum corneum. Dots cannot be used to define the lesion as melanocytic, but they can be used to help you differentiate between benign or malignant. Right? So here are black dots located in the center of this lesion. Here is magnified, so black dots. What do they represent? Melanin in the stratum corneum. And if you have a lesion with black dots, and if you wanted to prove to yourself that this is really in the stratum corneum, you just take some tape, put it on the stratum corneum, pull it, stick it on, pull it off, and most of your black dots will end up on your tape, okay? And so this is the same lesion a minute after tape stripping, and all these little black dots, there's a couple left, but most of them are gone, okay? That's just proof of principle. Brown dots are sitting below the stratum corneum, so D junction a little bit higher, and these obviously you can't tape strip off. So here are your brown dots. Now, brown dots, again, and so here's the nest below the stratum corneum. Now, brown dots, when you see these, you have to now look at their association with a network. If the brown dot occurs right on top of the network, you can ignore them. If the brown dot is not adjacent, not right on top of the network, it becomes worrisome. So here, notice that the brown dots are, here's the network lines, and each of the brown dots is right on top of the network line. That is benign. You do not have to worry about them, no matter where within the lesion they are. Why? Because they actually are these nests of melanocytes at the tips of the reed ridges. It's a sign of a benign nevus. That's where the nevus cells cluster in a benign nevus. And so here again, nest, and you see the dot right on top of the network line. Blue-gray dots represent free melanin or melanophages in the upper dermis. And here are your melanophages and melanin, histologically. And then red dots, this is not a melanocytic structure, but little blood vessels coming directly up towards you. Okay, the next structure, which again doesn't define the lesion as melanocytic, but has implications, is the crystalline structure. These are your short white lines that can only be seen with polarized light. And the structure represents collagen, and the reason that you can only see it with polarized light is that it's sitting deeper in the skin, so one, standard dermoscopy, the light's just not getting there. And two is that it becomes very bright with polarized because collagen is birefringent, and when polarized light hits the collagen, it just goes all over the place, right? It changes its angle of polarization tremendously. And so everything is coming back right off the collagen back to you. So it appears as bright white. So here's a melanoma seen with standard non-polarized dermoscopy, the same melanoma seen with polarized light. And here you can see these lines. And very often what happens is that these lines appear orthogonal to each other, meaning that if you actually look up here, there are lines going in this direction, and then here are lines going at 90 degrees in this direction. Okay, so line going this way and that way. So they're often seen orthogonal to each other within the lesion. Now, here's a hypomelanotic melanoma, but again, the crystalline structures are right in here. You can see them here. Now, what do these crystalline structures represent? As I said, this sort of collagen that we are seeing, but it's actually not just regular collagen, it's altered collagen. So it's somehow altered and abnormal collagen that appears as these white streaks. And in this one study looking at the histology of Spitz nevi with these crystalline structures, they found that it actually correlated with the fibroplasia, and so here's the fibroplasia that's occurring, and it's this that appears as these bright white lines. In a melanocytic lesion, if you see crystalline structures, your differential is only one of two things. It's either melanoma or Spitz. That's it. Okay? And if it's a melanoma, crystalline structures, if the presence of crystalline structures suggests that it's going to be a thicker, more invasive, more aggressive melanoma. Okay, regression structures. Now you know that regression structures, formerly known as blue-white structures, blue-white veil over a flat area, consists of two things. It consists of white scar-like areas, depigmentation, and peppering, right, granularity from the melanophages. And that combination gives you the regression structures and the blue-white veil over flat areas. So here, again, blue-white regression structures. And notice the white scar-like area, the peppering, and this is the blue-white over flat. And again, represents regression. Blotch is a concentration of pigment that obscures your ability to see any other structures where that, that darker blotch is sitting. So here, that's your blotch. You see nothing else, right? No other structures there. And histologically, it's melanin throughout all layers of the skin. And so you can't see anything. Now, it could also be just up here, but very heavy, thick melanin that just doesn't allow light to pass through. It becomes a blotch. And from a terminology perspective, the blotch actually can be one of two things. So remember I said, if you go back here, if it's only up here, blotch is termed a lamella. And if it's because of pigment throughout, then it's just considered blotch. Now, the lamella is something that can be tape stripped off, right? So here's a lesion that has a peripheral blotch, that if it were a true blotch would be concerning, okay? But if you just tape strip it, you'll see that that's actually just in the stratum corneum. So that's not a blotch, it's a lamella. Now, with that said, once you gain experience looking at these lesions, you can usually tell the difference between a lamella and a blotch. There is a textural difference between the two, but when you project them, you can tell them apart, and it's very difficult to put words and to articulate the difference between the two. It's a very subtle difference, but you'll grasp it as you see these lesions over time. It's a very subtle textural difference between the two. Homogeneous areas, basically what homogeneous area means is a structureless hypopigmented area. In essence, right, you could say, well, a blotch is a homogeneous area. It is. But by convention, what has occurred is that blotch is hyperpigmented. Homogeneous is really considered structureless, hypopigmented, but not depigmented, which would be regression. So that's a blotch, and that's a structureless area, okay? Both of them are kind of homogeneous, right? But when you read the term homogeneous, it's really referring to this, not that. And then structureless versus depigmented, okay? All right, now we have the blue-white veil over raised area, again, deep melanin and compact orthokeratosis. Here's your classic blue-white veil over a raised area. And you have your compact orthokeratosis and deep-seated melanocytes. So, summary of the local criteria that defines the lesion as a melanocytic tumor. Those are your network, aggregated globules, streaks, homogeneous blue. Pigmentation on facial skin, it's your pseudo-network pattern. On acral skin, it's your parallel pattern. And so here's your network, consists of both a pigment network or a negative network, either one, aggregated globules, streaks, and homogeneous blue pigmentation. Your additional criteria, parallel pattern on the palms and soles, and a pseudo-network pattern on the face defines the lesion as melanocytic. Then you have your vascular structures, which kind of briefly touched upon, and we'll talk more in a moment about those. And so here's a lesion that, if you think about, does not have any criteria for melanocytic from step one. And again, we'll get through the non-melanocytic in a moment, but basal cell, no features for a basal cell, no features for seborrheic keratosis, no features for hemangioma, and therefore now you're left with looking at the vascular structures, and so here you have these irregular serpentine vessels, those are one of the melanoma-specific structures, and this is a nodular melanoma. And then if it doesn't have that, then you end up in this last tier, the seventh step in this ladder, and that can be anything from a very light tan color to a very dark color to something that's undergoing regression. These are all by definition considered melanocytic because you don't want to miss a melanoma. And in this case here, tan lesion, it's non-palpable, and you have to be thinking melanoma. And your options in terms of what to do for this, as long as it's a non-palpable, right, so it's not a raised lesion, it's non-palpable, then your option is short-term mole monitoring. And if you don't have the ability to short-term mole monitor, then the only thing you have is biopsy. Okay, now, a little bit about short-term mole monitoring. One is never ever monitor a raised lesion. I'll say that again. Never ever monitor a raised lesion. And I'm going to say that one more time. Never ever monitor a palpable lesion. The reason for that is that if it's a nodular melanoma, a 1 month delay, a 2 month delay is detrimental. Okay? Superficial spreading melanomas is really not an issue. Okay? So the short-term mole monitoring protocol is only for flat, non-palpable lesions. So that's number one. Number two is that this short-term mole monitoring means that you have the ability to take a dermoscopic image of the lesion, store it somewhere, and when the patient comes back, you take another dermoscopic image of the lesion, and you put those two images side by side, and you make the assessment side by side. It is not you taking the one image and then looking at it live on the patient 3 months later, okay, and then going back and forth. It's actually looking at it side by side on the computer. And by definition, or the rule of short-term mole monitoring is any change. If that lesion changes at all in 3 months, then you're really committed to biopsy. Okay? If you do not have the ability to do this in your clinic, then for lesions that fall into that last tier, really biopsy is the only option.